네, 안녕하세요. 서산 두리치과 박종현입니다.
Hello, I'm Jonghyun Park from Seosan Duri Clinic. Today, I'm going to talk about IARPD. The unilateral side, there's abutment, and that could result in, if you put in denture, there could be rotation of dentures leading to complaint from patients. From the issues related to few remaining teeth, if you place like this implant and create implant clasp, it could have better result. With the implant being covered with insurance, patient can now go for this type of options. So in which area, how many implants needs to be placed? First, as you can see here, on the one side, if there's only 2 or 3 teeth remaining, on the opposite side, if you place implant like this, then this type of square type of support can be secured, and RPD that's supported on both sides will become more stable. Now let's look at a case. Number 44 was extracted after 1 year, 2 months later, and the denture the patient found too uncomfortable, and then 2 additional implants was delivered, and the abutment was also increased from 2 to 4 to have symmetrical support. And in taking impressions, typically it's same with the general RPD. Selective pressure impression was taken for the buccal support, and RPD was created. After 2 years, 2 months later, it was acting stably. The left side, the 4 years has lapsed. And what we are going to see now is from Professor Zhou's book. Cross occlusion. To resolve that, you have to place implant with that thinking, like this. The cross occlusion through implant, it can be, in other words, resolved. So where there's a lot of bone, most dentists want to go there, place implant. So in 2016, I ignored whether there's a cross result. I just placed implant, but the patient was not that satisfied. The bone width was narrow. So I thought it was tricky, but in 2021, where I had a better surgical skill, I could place 2 more additional implants. The bone width I thought was a bit narrow, but alveolar bone, after flattening it, like now, and removed very thin upper bone and placing implant there, it can actually, in many cases, be easier approach. And in case if you have to have a low or small fixture diameter, then I use for the non-hex fixture. So final prosthesis was delivered based on symmetrical support. Cross occlusion was removed, and with that became more satisfied. Now it's another case. In terms of the positioning, another thing that is important is to try to get as much as wide as possible. So 2 cases, if you compare, wider case, the case 2 patient has, of course, a higher satisfaction. Let's look at case 1. Mental lobe anterior loop was with that, you cannot go more backward, so it was impossible to come wider. So there was no other option. Even after allowing numbness to go more backward, I am opposed to that. So even after placing 4, this type of abutment is possible, and canine rest compared to occlusal rest functionally, of course, is less favorable. Second case, number 44, with the anterior, we avoided the anterior loop. And if there was more bone on the lingual side, and with that, we could avoid anterior loop. And with the guide, I think you can control the direction of placement. So we mostly follow the bone direction. And 4 implant was placed wide apart. Then it has more occlusal, favorable occlusal rest, more favorable than canine rest we have seen in the case 1. So with 4 implant, we could have more on the backward support. If it's a very old patient, I try to avoid GBR, so I try to put it on the lingual side. Finished IARPD, and on the lingual side, if you place in that there's sometimes a wide undercut. Of course, you could use leverage abutment in wider, but in insurance cases, you have to use abutment that's already available. So that's result. And if the class is on the upper side, it's not very aesthetically favorable. But with the few implant, again, I try to make it easier for patient. In other words, avoid GBR. So this is also something a bit lacking, but I think there's a lesson learned. If you have few implant, have the fixture wider apart and use pontic, then it's more favorable result aesthetically. The bone condition is okay, but I still place implant on the posterior side. If I, pushed it one more forward and create a 3-unit support, then I think patient might have become more satisfied. So again, lesson learned. Wider apart support, I think, is always better. But still, with the symmetrical support, the patient was satisfied. But what I'm saying is I could have done better. And as I said before, for older patients, bone grafting is something I try to avoid. Like this, if the bone width is even very narrow, then if you flatten, then the alveolar bone on the upper side, then there's still room to move. So after flattening, I place the implant on the axillary side. We use was and class IARPD was used for the mandibular side. So it's a narrow ridge, but if you flatten the upper bone without GBR, you can do bone implant plantation. So, place the 4.5 fixture. So I think it was more a bit thick, considering possibility of fracture. Now, a non-hex fixture would have been placed if it was me now. So flattening tools, there are many. I use straight angle round device. Because contra angle piece, you have a lot of load putting in, resulting in failures. So more durable, stronger, straight angle round denture burr is what I often use. So if there's few remaining bone, even with use of the denture, you use the remaining teeth to chew. So you try to use the natural teeth for chewing, and the denture is for supplementary role. So using it on the opposing side is very important. But after 4 years, another problem cropped up, and that I will talk about later. So if there's the bone condition is okay, then I think number 4 and 6 bridge placing on both sides is most advantageous. So like this restoration, and for long comfort and IARPD on the lower side doesn't really happen very often. And IARPD being covered by the insurance, I think it's still meaningful considering the common conditions of the patient. So what are things to be considered? Now, in all implant restoration, residual bone is important, and if the restoration is based on few implants, you have to really pay attention to them. Number 43 and 44 were used for implant placement, but it was placed to buccal side, and I think surgery should not finish with them. In case few implant is placed, then the placement location could have a lot of selection. So we switched number 45. and more satisfaction is better with the backside, and it's not really good to place it in the unstable position. And if it was 46 and not 45, then the abutment there would be wider support, so patient might have become more satisfied. But if there is not much of a space available, then you have to be careful. And for older patient is more economic conscious, it's not always you can use Pontic, so they don't want no additional cost. So there is a lot of compromise here. So for few implants, IARPD, the porcelain fracture can play a big role. So I prefer metal occlusion. So if the patient really wants the tooth color, then it can be less aesthetic, but I try to have this type of design where we can have strong metal support. And this is the case I've already showed you. In 4 years of IARPD came back, that's cannot chew very well. So with the few implants having a lot of load, inevitably there was fracture. Inevitably, overall, I lowered the occlusion and made the adjustment, and I had to pay with the lower vertical dimension. If the fracture was in the class where there was guiding plan, then you have to really start from the first step. So a fracture is always challenging. As a compromise, I know there's problem there, but I try to have minimum cost in treatment. After 1 year, there was extraction was made by another dentist because of a problem, and I hear the patient complained through the patient family. So if you try only think of money, there's this type of misunderstanding, and especially older patient who doesn't really fully grasp the situation. It's always challenging in explanation. And rather than the unstable natural teeth, full denture is sometimes better for the dentist. Few implant, in other words, in this situation can be maintained longer. In another dentist 2 years ago, IARPD was created like this, and 4 implants on the lower side used to create the IARPD. And here, something challenging happened in creating this. The short tray was used, but I would have made it even shorter if I did this now. So there was a lot undercut, and tray could not be removed very smoothly. Ultimately, using high speed, this thing was cut, and then I could remove it. So final prosthesis was okay, but it was not easy to remove everything, and patient, even after a lot of time had passed, still complains about it. And in case of IARPD, there's a lot of big undercut, so alginate impression needs to be used. So to try to avoid situation where I cannot remove tray later on. So for temporary restoration is something also requires careful consideration. If you place 4 and 2 both sides, immediate loading could be a good option. But if you compromise due to the cost, like this type of prosthesis on the temporary, the Pontic side on the lower part, the final prosthesis disappearing, if that happens, then patients start to complain. They say it's not as good as the temporary. So it's really challenging situation. I used guide, but flap was open, was placed, and linking with the cover screw. For comfort of the temporary, and because of temporary final, to avoid finals not being as satisfying, I think for dentists it's much better. So this might be using the temporary liner, it would be the best way to increase the satisfaction levels. So with the immediate loading in the final prosthesis, a patient is not as satisfied. And also, if you have only few teeth with the wax and silicone bites doing mouth restoration, you need to be very skilled. So here, if you have not attachment to the tissue, becomes unstable. So I do believe you have to use wax, wax or whatever. So because if you don't have a lot of stability there, it becomes really tricky. So I try to take abutment level bite restoration. There's a lot of immediate loading that I do, so using the abutment as is better. So same size, abutment is placed, and in the margin, I think using that, you would know if you have seen this lecture what I mean. So I prefer doing that for the final procedure. Using base plate wax, use the take bite registration and create temporary first. I think is what I often use. The pontic area on the lower anterior side, final procedure satisfaction level might be lower, so they don't really do that, but sometimes they still complain. So temporary is always tricky. With the temporary, you check the situation and go for the final ones. IARPD, that was economical, was used. Now, the bite residue with the temporary is now moved to the final stage. First, with the temporary there, using bite rate, the stop is created, and then the temporary was removed, and the bite tray was again used. With using silicone, it was taken on the front side. Or wax using that might be the easiest. Wax rim is using for bite registration. I do believe is has benefit. And especially with the few implant, in this case, using wax rim is more practical approach. So summary. Implant placing in a symmetrical position is important, and try to resolve cross occlusion, and if possible, make it wide as possible. These are things you need to remember. And in case in surveyed bridge, if you cannot visuals, then you could use the wax rim to take bite registration. So you have to study how to do it. And if the opposing teeth, even if it's a full denture, survey bridge needs not created arbitrarily. So the jaw relations needs to be taken into consideration. And for temporary restorations, you need to take a lot of things into consideration. I think temporary is always tricky in here. Older patients being patient is always hard, and persuading is always hard. And opposing teeth needs to be considered. If you've never done this before, the opposing teeth, the full denture is on the upper side, and class IARPD on the lower side. If you have that case, maybe that is where you need to start. And also, statistically, for female older patient than male older patient, the mastication they say is better. And rather than placing 2, placing 4 is always more favorable. So if possible, make up the treatment plan with 4 and persuade the patient. So what I want to say is, even if there's a lot of bone resorption, there's always some bone remaining. So place implant in a strategic position. If there is bone but no nerves, if you place implant there, of course, patient, they say it's better than nothing, but would not be as satisfied. If you really look for it, then even with the very minimum bone remaining, there would be a more favorable position. So there's always nerves that you think about, but rather than choosing lateral incisor, which is more favorable from the dentist perspective, look at the way where patient calcification goes up, wide support. On the anterior side, it might be easier for the dentist. but for patients, it's not be as satisfying. So temporary restoration, I say, is always challenging. And I feel ultimately immediate loading is more practical way because you place immediately after extraction. So cover screw submerge and using temporary tools is not always smoothly, but the most satisfying way for the patient is using the immediate loading. Then the final prosthesis when you do that is always lower.
이렇게 되면 최종 보철물을 했을 때 만족도는 늘 떨어졌던 것 같습니다. 네.
So implant and using that with IARPD is what we looked at, and as it can be covered by insurance in Korea, so it's economically more attractive. So patient satisfaction is also higher. So if you try with what you learned today, it will be very useful. So thank you for listening to this lecture. Thank you very much.